Today is the 101 episode of ECG study group presentation, ECG Basic and Beyond. And today our presenter is Dr. Abdullah Al Mamun. He has completed his MD Cardiology from NICVD in 2023. A very young and energetic physician, and he has keen interest on ECG. So unlike other presentations, we are cutting short the introductory phase and going to present the session directly. I'd like to request Dr. Abdullah Al Mamun to present his presentation.
Share group of share.
Mamun, please share your presentation.
Is it visible, my presentation?
Yes, yes. Start from the first slide. Okay.
Is it working?
It's working.
Yes.
Start from the first slide.
This is the first slide.
Okay. Go to the full view.
I already go to the full view.
That's the next one.
Okay, start your presentation, please.
Yeah, okay.
मामून तुम्ही स्पीकर व्यू तो जाओ स्पीकर व्यू पे
स्पीकर व्यू पे जाओ
स्पीकर व्यू কোথায়
জাস্ট মাউন্ট বাই জাস্ট এই যে ডিসপ্লে সেটিং এর ক্লিক করেন
না ওখানে
প্রেজেন্টার ভিউ
yeah right presenter view
আচ্ছা আচ্ছা না ডিসপ্লে সেটিং ওকে
এই হাইট প্রেজেন্টার ভিউ আসছিল হাইট প্রেজেন্টার ভিউ আসছিল
হাইট প্রেজেন্টার ভিউ দিব
জি
ঠিক আছে স্টার্ট মামুন
আসসালামু আলাইকুম honorable chairperson, respected teachers and dear audience, welcome you all to my presentation. Me, Dr. Abdullah Al Mamun from NICVD. First of all, I would like to thank ECG study group for giving me the opportunity for presenting here in front of renowned cardiologist. From the very beginning, I have followed the ECG session of this group, and this session helped me a lot during my academic journey in cardiology. So I am really grateful to this ECG group. So in my presentation, I will share 4 cases that is from real-time scenarios that I encountered during my medical practice. Am I audible?
Yes, Mamun.
Yes, you are audible. Please proceed.
Hello. So this is the first case. My first case regarding 15 years old boy who presented to us with the complaints of the palpitation for 6 hours. On query, he denied any history of chest pain, breathlessness, syncope, or any. There is no family history of sudden cardiac death. Our examination patient's pulse was 180 beats per minute, and other vital parameter was normal. With normal precordial findings. Here is a 12-week surface ECG showing normal standardization and calibration. There is showing regular rhythm, and there is tachycardia at a rate of 180 beats per minute, and P-wave seems to be absent, and QRS duration is narrowed down to 80 milliseconds. So this is a regular narrow complex tachycardia. Most likely as supraventricular tachycardia, and there is also some STT changes. There is ST depression in V3 to V6, and also in 1, 2, and AVF, and there is also ST elevation in AVR. If you look at the lead 3, there lead 3, the amplitude of the QRS complex is vary. The taller complex alternate with a smaller complex more than 1 millimeter, that is electrical alternance is also present. So regarding considering these ECG findings, we have a poll and we have multiple choice. So I would like to the participant to answer this poll. Please start the poll.
কামরুল ভাই একটু পোলটা দেন for 10 seconds.
So anybody comment from the audience can comment on the CCC or
Mamun, why did you omitted the option AVNRT?
sir ABN একটা অপশন স্যার আমার স্লাইডে দেখা যাচ্ছে স্যার ওখানে
কোশ্চেনিয়ারে তো নাই
জি স্যার ওরা সেট করতে বলি আনসার কিন্তু নাই স্যার কিন্তু আমার এখানে স্লাইডে দেখাচ্ছে ইট ইজ দ্য ফার্স্ট চয়েস
হ্যাঁ
জি স্যার
তো কাজে আনসারিং তো ঠিক হবে না
জি স্যার
So Mamun,
yes sir, yes sir.
So most of the participants answered AVRT, na?
Yes, yes sir.
আদারওয়াইজ এটা হয়তো কম হতো কারণ এভিএনআরটি ওই আনসার কিতে ছিল না কাজে সবাই ওইটাতে দিছে
হ্যাঁ তা ঠিক But however the answer is correct.
Yeah.
Yes sir.
So Mamun, you
Anyone from the audience to clarify the ECG?
Yes sir.
Anyone from audience, if want to clarify the ECG, can raise
your
the
hand.
or show interest.
There is one.
Dr. Shariful Halim.
Shariful Halim.
Yes, connect him.
Connect him.
Assalamu alaikum, sir.
Wa Islam.
Sir, thank you for letting me join the session. Sir, with this ECG, this is a narrow complex tachycardia where I don't see any POF before the QRS, but there seems to be a retrograde POF after the QRS, and this seems to be a short RP tachycardia. So I have some differential. My first differential is AVNRT, and my second differential is AVRT, and another differential is junctional tachycardia. So I have those differentials in my mind.
Which one most likely?
Shariful.
Sir.
What is the point?
Which one is the first number one? Among these three?
Number one, AVNRT.
AVNRT.
Sir.
Shariful, how can we exclude sinus tachycardia? As because you can see the POFs in V1. What are the points against sinus tachycardia?
Sir, usually in case of sinus tachycardia, the POFs in V1 should be, if it's sinus, the POFs in V1 should be biphasic. But here it's upwards, not biphasic. So this is probably not from sinus.
Excellent, thank you very much. And there should be positive POF in lead 2. That is, there is no positive POF in lead 2, and your answer is absolutely correct. That is, the POF is not looking normal in case in V1. That is, it is just a very small and positive, so it is unlikely to be sinus in origin. So it is the point against sinus tachycardia. So,
Shariful.
Sir.
What is the point against AVNRT in this ECG?
Sir, the retrograde P seems to be a bit far away from the QRS.
Okay.
So that goes in favor of AVRT, I think. It's
Any other point?
and
Any other
electrical
point?
alternates.
Yes. Yes. It's a very important finding.
Yes, sir. There are 2 points basically. One is
Yeah.
though it's short RP, but RP is more than 80 milliseconds from the J point. And another is the presence of electrical alternates.
Alternates. So let's proceed, Mamun.
Sir, I cannot see the slide.
What happened, Mamun?
Should I share again? I cannot see my slide.
Share it again, please.
Visible? Is it visible?
Yes. Go to presentation mode. Showcase.
Okay.
In the lower panel, there is presentation mode in your computer at the PowerPoint presentation.
I cannot. There is no.
Yes. The size of the slide, there is a scale at the bottom right side.
My
Before that,
arrow mark
before
is
that,
not working, sir.
it's not
Arrow mark.
working.
Kamrul bhai. Hello.
কামরুল ভাই আমি আপনাকে প্রেজেন্টেশন পাঠাচ্ছি ওর প্রেজেন্টেশন আমার কাছে আছে আপনি এখনই শেয়ার করেন somehow ওর কোনো প্রবলেম হচ্ছে I'm sending it to you.
না আগেকার মতো ইয়ে করো মামুন আগে যেরকম গেলে না ওই যে
স্যার
প্রেজেন্টেশন
মাউস ওয়ার্ক মানে কাজ করতেছে না দেখে আরেকবার পারি কিনা স্যার?
আর আপনি বন্ধ করে শেয়ার বন্ধ করে আবার শেয়ার করুন তাহলে
না তুমি বক্সের বাইরে গিয়ে ক্লিক করো তো ওই যে ইয়ে হয়ে আছে বক্সের বাইরে গিয়ে ক্লিক করো
এই যে এটা। আচ্ছা আমি এটা দিচ্ছি। এবার দেখা যাচ্ছে?
জি
হ্যাঁ
হ্যাঁ,
এই তো
এবার দেখা যাচ্ছে। গুড।
Thank you, sir. So this is the regular narrow complex tachycardia, and if we look at the leads at zoom view, lead 2 and V6, there is a presence of retrograde POF, as Halim mentioned nicely. And there is, if this is POF, the RP interval is shorter than the PR interval, and RP interval is more than 90 seconds or 80 seconds. So along with this ECG finding, there is also presence of ST depression, ST elevation in AVR, and also presence of electrical alternates. This favors the diagnosis of AVRT. And this is the algorithm in case of narrow complex tachycardia. And I make it short in the right side of the slide. In case of the regular narrow complex tachycardia, the POF is absent and there is presence of pseudo-S or pseudo-R. This is AVNRT. And if retrograde POF is present and RP interval is less than 90 milliseconds, that is AVNRT. And if there is short RP and RP interval is more than 90 milliseconds, that is AVRT. And in case of long RP tachycardia, the most likely diagnosis is focal atrial tachycardia. So we treated the patient as hemodynamically stable. Patient was hemodynamically stable. We treated the patient. We first tried for the non-pharmacological approach, that is carotid sinus message or valsalva maneuver. As there is no response, then we tried for IV adenosine in incremental dose with IV saline infusion, rapid saline infusion. And after here is the monitor ECG. Before and after the adenosine, showing the rhythm is reverted to sinus, and 12 lead ECG was recorded after immediately after the reverted to the sinus rhythm, and here is the 12 lead ECG. So I would like to make a poll regarding this ECG. Please let. Okay.
The second case.
No, sir. This is first continuation of the first case, not second case.
Kamrul is not case 2.
It is case 1. Again, I'm not seeing my slide.
We can see.
So anybody from the audience or panelist can comment on this.
Yes, again, Shariful.
Thank you, sir.
There is
So-
nobody other than
Should I continue?
Shariful. Yes.
Okay. I cannot see the screen actually.
Screen gone.
Screen.
Okay.
Reshare. Okay. Before. Yeah.
So this is a 12-lead ECG with normal calibration and paper speed, and the heart rate is around 100 beats per minute, and the rhythm is regular. The axis is there is right axis deviation, and there is the P waves are normal in morphology, but the PR interval is short, and the QRS seems to be wide with an initial positive deflection suggesting delta wave, and there is presence of ST depression and T inversion in almost all the leads, including the anterior leads and also the lead 3. And there is an RBB morphology in the lead V1. So I have some differential. My first differential is this could be, sir, WBW syndrome, WBW ECG pattern type A, but as the patient has history of SVT, I'd like to call WBW type A ECG pattern.
So, Shariful, thank you very much for your excellent mode of description. That is in a very academic way. That is nice description.
Thank you, sir.
Might be the pathway, Shariful?
Sir, as B1 is positive, the pathway may be coming from the left side, sir.
Okay.
Left side. Yes, sir.
That is left
Should I
side.
proceed, sir?
Okay. Now, Shariful, can you more localize the pathway? That is in the left side. There is also pathway, the localization that is lateral, posterior, anterior. Do you have any?
Sir, as the inferior leads are positive, so I think this may be left lateral, left free wall maybe.
True, you are absolutely true, correct. That is the, it is not the posterior as because lead 2, 3, that is 2, 3 AVF is positive, that is coming from about downwards. And lead 1 and AVL is negative, so it is coming from the lateral wall, that is left sided free wall or lateral wall. Yes, thank you very much.
Thank you, sir.
Can I proceed, sir?
Yeah, sure.
Yes, Mamun. So that is the end of the case 1, na?
No, sir. There is. So we are. Thank you, Shurbhalamin, for nice comment. So the PR is short, and there is the presence of delta wave, and there is positive delta wave in VU1, and so this is WPW syndrome, type A, and sir exactly say that accessory pathway is from lateral LV free wall. So the next day again it was done, and they shown this the giant wave inversion has gone, and other ECG finding was normal. So finally, his diagnosis was regular narrow complex tachycardia due to the orthotomic ABRT, and which was reverted to the WPW type. So here is the arrhythmia that is associated with the WPW syndrome, and the most common is orthotomic ABRT, which shows narrow complex tachycardia, and another one is free excited AF, and another one is antidomic ABRT, which is present as wide complex tachycardia. In orthotomic ABRT, the atrial impulse enters into the ventricle through the normal AB unit. So ventricle is activated through the normal pathway, so QRS is narrow. But in case of orthotomic ABRT, ventricle is activated through the accessory pathway, so it shows that wide complex tachycardia. So we treated the patient with verapamil and referred to the electrophysiology unit for definitive management, that is EPS study and radiofrequency ablation. And here is the localization of the accessory pathway. In our case, there was positive delta wave, and there was negative delta wave in one AVL. So it's from free wall, LV free wall. So end of the first case. Can I go to the second case, sir?
Yeah, sure.
So the second case is regarding a 45-year-old male with the first medical history of diabetes mellitus and smoking, who presented to us with the chest pain for 5 hours, and pulse was 72 beats per minute, and other vital parameter was normal. Here is the 12 leads ECG. There is no fault, but anybody can comment on this ECG.
Any volunteers, Soriful or Atahar?
Sir, yes, sir. So this is another 12 lead ECG with normal calibration and paper speed. The rate is around 75 beats per minute. Rhythm is regular and sinus, and PR interval is normal. QRS duration is QRS is wide in lead V1 with RBBB type morphology, and there is ST elevation from V2 to V4 and lead 1 and AVL, and there is also reciprocal ST depression in the lead 3 and AVF, and the QT interval is normal. So I have some differential from this ECG.
There is also presence of QOF.
Yes, there is also presence of QF in the V1 to V3. V1 to V3, yes.
Okay, Soriful.
Sir. Sir, based on the history and the patient's ECG, I have my first differential would be this could be acute ST elevation MI anterior, extensive anterior with RBBB. With RBBB.
Okay, right.
Any other differential?
This could be, sir, another differential could be, sir, pericarditis, but I mean, it would be my second differential. But there is no other features of pericarditis.
So, Mamun, what was the presenting symptom, Mamun?
Chest pain, sir.
Oh,
Patient presented with us with the chest pain, ischemic central chest pain. Should I proceed, sir?
Yes.
So anterior my RBB. So what is the culprit artery? If we look at the at this diagram, It's shown that here is the LED
Acha,
and
acha,
here is the septal branch.
acha, Mamun. Before that, is there
Here is
Azizul
the
bhai?
septal branch, and we can see this, sir.
Nah, Dr. Azizul bhai from USA?
Sir, Ajit sir, are you listening? I think, sir, he is busy in practice. Sir, I have a question to you, Atahar sir.
Hmm.
Shariful Halim was mentioning RBBB in presence of entry-MI. Is it important to mention presence of RBBB in entry-MI, acute entry-MI? And if that, why so?
Yes, definitely RBB should be mentioned as because this has got very important clinical importance. That is the presence or absence of the RBB. And the diagnosis of RBB in case of presence of MI does not follow the classic rule. If there is positive R wave, that should be considered as that is right band of blood. So it must be mentioned.
Sir,
So
if
my question
someone
was,
miss, sir, for the trainees or for others, if someone misses RBBB in presence of entry-MI, does it have any bad clinical implication for patient management or counseling of the patient regarding the MI?
Yes.
Atahar sir.
that is presence or absence of the RBB in case of anterior MI is very much important for risk stratification of the patient and predicting the subsequent prognosis, as because the presence of RBB indicates very proximal lesion, very big infarct area, very high risk of developing the ICM and other subsequent concomitant conduction disorders that may need the subsequent pacemaker or like this. So it is a very much important, one of the worst clinical association with the entry-MI. It is one of the worst clinical association with the entry-MI. There is a right bundle plus block.
Could it lead to complete heart block? Otherwise,
Sorry?
the
Yes.
patient has
Yes, sir.
already right bundle branch block, and he is having anterior MI, so it might cause anterior fascicular block.
Yes, yes.
That is
definitely.
left bundle branch block, and
True.
ultimately by both bundle branch will lead to complete heart block.
And yes, yes. That is left bundle branch block. And ultimately, by both bundle branch will lead to that is left bundle branch.
Sir,
Hello.
Dr. Shubik, sir.
Shofik,
Sir, as it is RBB, actually, right bundle already been damaged. So first
Yes, sir.
septal branch should lesion before first septal branch.
Yes, sir. Yes, sir. So
May I
here is
add
the
one point? May I add one point? Atahar sir.
MG,
Yes, may I add one point?
sure, sure.
First query from Tushar. It is definitely elevation MI, extensive anterior, with the evidence of RBB. So once you see any findings, you should mention. Number one. What is the importance of this issue? Issue is that anteroseptal MI with RBB, it means proximal relation, most likely prior to S1 level or proximal to S1 level. So it has immediate threat. Patient might have developed anytime, any moment may eventually develop complete heart block as well. Patient may need temporary pacing as well. Question is that actually how we should tackle it. If it develops complete heart block, should I go for primary PCI first or go for rhythm fix first? That will be the another issue in the later on for the management perspective. But it gives a clue. It might be a devastating case, proximality, severe lesion, impending to complete heart block. So we should give immediate attention to tackle this situation, and we should take appropriate measure, and we should prepare for the next steps. This is my comment, sir.
Azam, he might require both at a time, the primary PCI as well as temporary pacemaker.
Sure.
Correct.
The question is that, sir, question is that rhythm fixed first, then he should send the patient the cath lab, go for primary PCI, and keep the TPM. If rhythm is reverted, even though reverted, he should keep the TPM lead at least 24 hours. If not reverted, at least he should wait for 5 to 7 days. If not, then we should consider for permanent pacemaker.
Just a query. If there is a right bundle branch only, what is the way out to revert the RBB to normal without doing primary PCI?
Now, this is estimation MI with RBB. You have to go for primary PCI. There is no way. Or primary PCI or thrombolysis. What facilities you have?
Right.
This is the class 1 indication.
Correct. So that is without doing primary PCI, nobody can expect to revert the condition.
Right.
Yes, sir.
Yeah.
Another thing is in interceptal MI with right bundle branch block, most likely the right bundle branch block was pre-existing as a normal variant.
I do differ. Sir.
That is more common than developing right RBB for MI.
No, it can be happened because of the septal branch involvement. RBB might develop due to MI itself, and that is dangerous.
But it,
that might progress to complete heart block.
Yeah.
Jamil.
Ji.
In case of the that is the pre-existing RBB and newly developed RBB after the STMI, there are some ECG changes as because in case of the pre-existing RBB, most of the time it is the classic trifascicular form of the QRS complex in V1 and V2. But after the MI, the newly developed RBB may not follow the classic trifascicular form. It is the positive R wave. That is the R wave greater than the S wave in case of that is the V1 that signifies the presence of the RBB. Here you can see that is it is only the positive R wave. There is no classic trifascicular form. That is RSR form. It does not need to qualify the diagnosis of the so it is almost sure that this is the newly developed RBB after the MI. So there are some ways we can differentiate between the pre-existing RBB and the newly formed RBB. And these RBB, unless it is accompanied by some other conduction disorder, only per se, this RBB does not qualify for the pacemaker. It should
actually what Mamun wrote, small r, small s r, capital R. But here it is only QR pattern.
Right,
not,
QR pattern.
Not RSR pattern in V1.
So there is a small tiny
one,
spike.
That one is fits with what Atahar told.
QR pattern has. It's a QR pattern.
It's QR pattern, but he's saying a very small spike. That's why he mentioned, I guess.
But the important message is that it is not necessary, Mamun, to a small r should be there. It may be absent. The only QR
Yes,
is
sir.
only QR is there is the this
QR pattern can be RBB, sir.
Yeah.
So should I proceed, sir?
Yes,
Sure.
yes.
Okay.
No.
As Azam sir mentioned, this is a good candidate for primary PCI, but in our center, primary PCI is not available over 24 hours. So we treat the patient conservatively. We thrombolyze the patient along with the other medications. But unfortunately, after 1.5 hours of thrombolysis, patient developed this ECG. So
Complete heart block.
yes, sir. So so the rate is about 38 beats per minute, and rhythm is regular, and there is multiple POFs between the ROFs. So and RR fixed, and PP interval also fixed, and look at the PR interval. It is variable in all of the rhythm strips, all over the rhythm strips. So there is complete heart block. and there is also ST division and pathological Q wave in the anterior and lateral leads. So the ECG diagnosis now is STMI, extensive anterior and complete heart block. So here is the ECG, another ECG of this patient. So anybody, here is a pool there, here is a pool, so anybody can comment on this. Or please start the pool.
It is very much said.
Please start the pool, please.
নাই তো না যে বসাই দিয়েছ উপর সাততলা আছে খোলা নি না বন্ধ
Azam, mute yourself.
Kamrul, poll, please.
Sir, pool is not showing. Can I describe? Should I?
So we can
Proceed for discussion, please.
Shariful.
Yes, sir. Sir, this is another 12-lead ECG with normal calibration and paper speed. The rate is around 100 beats per minute. Rhythm is regular. There is P wave before the QRS complex. I can see them in lead V2 and V3, but there is an extra spike before the QRS complex, which is present in before almost all the QRS complexes, and the QRS is wide and has an LBB pattern, and there is STT changes, which is there is ST elevation. Still there is ST elevation in lead V2 to V5. So this is a pacemaker pacing ECG. It seems to be atrial sensed and ventricular paced.
Oh,
No,
no.
no, Shariful.
Or I have another differential, as the patient had complete heart block. Another DD, this could be, sir, single chamber pacemaker, and there is some extra P waves there seen as part of the complete heart block.
You
Oh, no,
know the
whether P
scenario
is
of this
all the-
patient, Shariful.
Sir?
You know the scenario of this patient. So that patient developed
Should be.
complete heart block, and what should be? Could be this. What kind
This
of
could be, sir,
pacemaker?
sir. Usually, sir, we put the temporary pacemaker. So
Yeah.
first DD should be actually
Single.
VBI pacemaker should be, sir.
Single
Sorry, sir.
chamber?
First
Single
should be,
chamber, RB pacing.
RB paced, sir.
Yeah.
Single chamber RB paced, sir. Sorry, sir. It should be, sir, single chamber.
And you missed one standardization, normal in limb leads, half in the pectoral leads.
Oh, yes. Sorry, sir, missed it.
Another point is P wave not preceded by all the QRS complex.
yeah.
Yes, there are some POFs in the
Some POFs,
chest
not
lead,
all.
but I could not see the POFs in other leads.
So Shariful.
Sir.
Initially you told that is the dual chamber pacemaker, na?
Yes,
So-
sir.
So, by the way, how you can exclude the possibility that is it is not the dual chamber, it is definitely the single chamber?
Sir, if it's a dual chamber pacemaker, usually we should see either pacing of both atrium and ventricle. So pacing spike should be before P and QRS, or it
Right,
could be,
there
sir,
is no
atrial
pacing spike
self.
in atrium, true.
Yes, sir. There is no preceding pacing spike before the P, or it could be atrial sensed and ventricular paced.
True. Thank you
Yes.
very much.
Or it
That is
could be
the P
atrial
is
sensed
not
and
flagged. That
ventricular
is P
paced,
will be
which
changed.
yes.
That is the P
Yes.
will be changed. There will be
Yes.
that is programmed
Sir?
AV delay followed by the QRS. That is not the sequential pace. There is no evidence of the sequential pacing, so it is unlikely to be the dual chamber pacing. It is
Yes.
likely to be the sequential pacing. Thank you very much.
Another point is there is also present of as a in lead 2 or lead 3 there is a
Yes, sir.
C division bit, sir. The look like
Thank you,
there
sir.
is a spike but not white. So white is it, sir, a C division bit? I marked in circle.
Yes, there.
Sir, I guess it's fusion, sir. It's not pseudo fusion. because
Oh, fusion.
the
Oh, fashion. Sorry, sir, printing mistake.
the complex is in between the pacing beat and the normal beat. So it's a pseudo fusion. It's fusion basically.
Fusion. Okay, sir.
Pseudo fusion will
Sir,
be the pacing spike will be there. Okay. Hello.
sir,
Hello?
police. Hello.
So you want another poll?
No, sir. He.
Cancel this one.
Okay, sir.
Amrul, this already discussed. Please proceed, Mama.
আবার দেখতেছেন।
Jamil sir. So he mentioned one thing that pseudo fusion. Can you just please sir clarify for the those
Pseudo
who
fusion.
did pseudo fusion and pseudo fusion in pacing it?
Jamil, let me clear.
Sir.
There are three terms actually: fusion, pseudo fusion, and pseudo fusion. There are three terms. Fusion means there is the participation of a complex by the two chambers, like the that is the WBW. It is a fusion beat. Here it is the captured beat. That is a one chamber is paced and it is fully captured. When the captured beat, when there is a fully captured, it is a captured beat. And when there will be a capture will be partial, that is the spike will be not before the QRS complex, just over the QRS complex like the T. It is called the pseudo fusion. And when the spike will be from the other chamber, it is called the pseudo fusion. As for example, that is the P spike will be QRS complex and there will be some capture. It is called the pseudo fusion. So captured beat, pseudo fusion beat, and pseudo fusion beat. These are the three terms.
Okay, sir. So this is a single chamber RB pacing, as discussed. So after next morning, the patient was taken into the cath lab with the intention to do the rescue PCI, as there was a failed thrombolysis. So here is the series of the lab system showing the L6 is diseased from the distal segment, 98%, 95%, and LAD is also diseased from the proximal segment, and the right system showing the diffuse disease from the proximal segment. So patient got STMI with complete heart block and multivessel disease. So what should be the next steps of this patient? So here is the some options here. So we can discuss on this.
I have just a question, please. That is one thing. Patient taken to cath lab in next day. Why it is called
Next
rescue
morning.
PCI? Next morning, but why it is called rescue PCI? Rescue PCI should be after 1 hour if ST elevation not resolved 50%. But in next it is delayed PCI.
Delayed. So it
Right.
can be
It
delayed.
is not rescue PCI.
Just call it pharmacoinvasive within 24 hours.
Pharmacoinvasive.
But pharmacoinvasive could be.
Yeah.
But pharmacoinvasive if ST elevation is if ST elevation normal or more than 50% resolution, then it is pharmacoinvasive. Other rescue PCI indicated but not done, delayed.
Sir, because of pacing spike TPM, we cannot be sure the presence ST resolution or not.
Right.
So
That's one question.
pharmacoinvasive can be an option,
Yeah.
optional term in this case.
Actually, it is a clear-cut case of after thrombolysis within 3 to 24 hours. That means it is maybe a category as a routine PCI.
No, still it is pharmacoinvasive.
You can say it, but is
Mhm.
it because rescue PCI or pharmacoinvasive PCI? There is a definite clear-cut definition. You can put it here is a just according to guideline after 2 hours to 3 hours to 24 hours, you put it in just like routine invasive strategy like that. Question is that actually how we should decide this case. Should we go for infarcted artery, then PPM. That is the main issue of discussion. Dr. Mamun, right now, right?
Yes, sir.
So you
Should we
can
discuss
go
or
for pool.
let the
Yes,
poll
sir.
happen?
We can create a pool.
Kamrul,
हम घूमे के समय है.
No, sir, I think he is busy, and this dilemma is better to be discussed by the specialist, I guess. I'd like to request Dr. Abdullah Ajit sir, if you're present, or MJ Adam sir, to have his view. Adam sir, what is your view as a interventional cardiologist? What you do in this case?
As I said earlier, actually, stimulation MI and RBB potential threat to develop complete heart block any moment. So, any interventional cardiologist, keep it in mind. I am anytime face complete heart block situation. So, primary piece is the first option. If develop complete heart block, then TPM. Then what next actually? Then at least if it is treated by primary PCI, then we can wait at least TPM for 24 hours. If it is revert, then we can remove it. If not revert, then we can wait for 5 to 7 days. Then we can consider for rhythm fixation by implantation of pacemaker. But
will you
in
go-
that
will
case,
you go for a complete revascularization or culprit vessel?
yeah, that is the $1 billion question actually. Till today I can consider complete revascularization, but last year, if consider the last year, then I can go for only infarct. Right now, we are telling, if possible, go for complete revascularization in the same settings. So,
Same setting or same admission?
same admission, you can, same settings, it is one option. If it is not possible due to any other reason, if patient may shock or huge dyes consumption, then you can make it in same admission or index hospitalization. You can for 48 hours or 72 hours later on, you can go for the next vessels. You can give us this.
Assume one thing, patient having extensive anterior myocardial infarction. So at this moment, why not stage PCI is more superior than complete revascularization in one setting. If there is any disaster in other vessels, then patient will die in the table.
Yeah, if you look at the culprit shock trial, right, then they are recommended for infarcted artery, then stage. If you go for complete trial, then they recommend you can go for reconstruction all bases if there is no hemodynamic deteriorations. So that's why right now, almost all the time, it is recommended whenever possible, you go for try to complete revascularization. If not known, no other contraindication or any adverse situations. So preferably, you can go for complete revascularization in the first setting. If not possible any other way, then you can consider in same admission hospital. If it is not possible, then you can go for 42 days. Then you can go for complete revascularization.
Azam, this complete revascularization, does it come to the practice guideline or?
Yeah.
Plus-
What
plus-
recommended guidelines?
এখন ওটা গাইডলাইনে আসে নাই, এখন
Guideline-
রিকমেন্ডেশন, নতুন রিকমেন্ডেশন স্যার, কিন্তু গাইডলাইনে আসে নাই।
আচ্ছা, consensus opinion?
না স্যার, এটা আপনি দেখাও, মামুন আছে না, এটা দেখাচ্ছে বলবা?
আর একটা আহা গাইডলাইন ছিল, একটা স্লাইড আমি রেডি করছিলাম স্যার,
মামুন,
দেখে
লাস্ট গাইডলাইনের জাস্ট ছবিটা দাও, গাইডলাইনের ছবিটা দাও, লাস্ট যেটা আমাদের এস্টাবলিশ হয়।
এখানে বলছে স্যার it said that if is it visible, sir?
হ্যাঁ, ভিজিবল।
It is visible.
Yes, sir. In case of cardiogenic shock, if there is cardiogenic shock, routine revascularization non-culprit artery is they say that it's harmful, but and in that case defer routine non-culprit revascularization, but there is some issue. Non-culprit artery supplying a large area of myocardium at risk of and absence of multiple comorbidities. If if the non-culprit artery is not complex, that means simple. In that case, if the complex multivessel non-culprit artery disease, if there is no complexity of the non-culprit artery, we can go for a stage PCA of the non-culprit artery. It is class 1 indication.
Correct.
Sir, as our experts say, if we make it simple, in case of in case of acute MI, if the culprit artery is doable, if there are other arteries also involved, and the clinical context of the patient allows us to address the other arteries, then only we go for the other arteries. Otherwise, we'll do the culprit artery, follow the patient, and if possible, in index hospitalization, we will treat the other arteries as well.
Culprit vessel.
Am I correct, Adam sir?
একদম
Yes.
100% পারফেক্ট।
Problem
যদি
is
hemodynamic স্টেবল থাকে, যদি দেখো যে not too much complicated other bases, if you can fix it up same settings.
Yes, sir.
Yes. In
As
our
well.
context, I think in our context, Bangladesh context, I think that will be the easier and approachable thing. Do the culprit artery first, and if the patient stabilizes and the things are okay, then before discharge, other arteries should be addressed as well.
কিন্তু problem কি, in the same index admission we cannot convince the party and the patient. When they feel better and the relatives see the patient is stable, has no symptom, they opt for or defer for the other vessel PCA. So we have to wait for another 1, 2, 3, 4 months. Sometimes patient doesn't come back within
Okay,
a
sir.
year.
Sir,
That's the
now just
practical
another
problem
part.
with our people.
No,
Sir,
sir, but
another
still,
part.
counseling is one of the important parts.
Yeah, we counsel it nicely. What the benefit, what the merit, what's the dealing, what may occur, what harm may occur. Even then, the party doesn't agree with our recommendation.
Okay, sir. Just now, I have the from the students' point of view. When do you do pacemaker for this patient, or you will go for ICD?
ICD
After 40
এখন
days.
তুষার prophylactic ICD কি এখনো recommendation আছে?
No, no, no. As a আমি recommendation নাই, আমি আপনার কাছে as a student হিসেবে মানে বলছি যারা
If the
আপনার approach
ejection fraction, if the ejection fraction goes down, then you can consider for ICD. Or the patient develop VT subsequently later on, not as primary VT, secondary VT. Then we can consider for ICD.
When? After 40 days or?
Usually after 40 days.
Right. Whether permanent pacemaker, when we want to put the permanent pacemaker?
In this patient, as he developed complete heart block, and if after revascularization it does not come back to sinus and it persists, then this patient is candidate for ICD too.
This is a in this patient, whether the chances of reversion possibilities, how much? That is a question.
Maybe less than single
Maybe less.
vessel, as it
Sir,
is multi-vessel.
So now the guideline is already clean cut. They have mentioned in the segment that the slide is already shown.
As I mentioned, sir, at least 5 days I have to wait
At least
for
5 days.
validate legal
Yeah.
issue. But in my practice, I am waiting at least 7 days. At least 5 days is okay if you go for permanent pacemaker. If you want to wait for more days, you can wait up to 7 days as well. It's up to you.
Class 2B is CRT or CRT
Yes, sir.
D or
Early
T.
device interpretation is class 2B. So
Now
I have
question
also,
to the
I have
Atahar Ali
two
sir.
more cases.
মামুন, আতার আলী স্যার আমাকে
জি,
শুনতে
স্যার।
পাচ্ছেন স্যার?
হ্যাঁ আজম,
স্যার আমরা পেসমেকার করলাম, 7 দিন পরে, তারপরে আমরা তাকে ফলো আপ করলাম 6 সপ্তাহ পরে, ইজেকশন ফ্র্যাকশন 40%, তারপরে আমরা তাকে আবার 3 মাস পরে ফলো আপ করলাম, ইজেকশন ফ্র্যাকশন 30%. Then and with same time optimization of GDMTT, ABCD antiplatelet, beta blocker, cholesterol lowering agent, dilators and SGLT2 inhibitor দেওয়া হলো, তারপরেও তার ইমপ্রুভ করে নাই 30%. QRS complex 140. What will be your plan actually?
Actually, three things we have to consider. There is the functional class NYHA, then conduction disorder, that is the either single or combination of the conduction disorder, that is it is only the AV block or combination of the AV block with the fascicular block. Then presence or absence of the sustained hemodynamically unstable VT or the cardiac arrest. These are the three things we have to consider. That is that there is no cardiac arrest, no VT, only the ejection fraction less than 30, functional class 1. Class 1 with less than 30, class 1 criteria for the device therapy. And if there is a pacing criteria, Brady criteria, you have to go for the CRTD. Otherwise, it is the ICD. So only class, that is NYSA class 1 is okay if the ejection fraction is 30. But if the ejection fraction is less than 35, then you have to go for the NYSA class 2 to 4. That is ejection fraction less than 35, functional class 2 to 4. There is no need of the cardiac arrest or something else. It is only the ejection fraction that qualifies for the ICD therapy. But if there is combination of the conduction disorder, you have to go for the CRTD. But if the ejection fraction is less than 40%, then you have to go for the, and if there is no conduction disorder, then you have to go for the EP study. If the ejection fraction is 40%. So less than 30, 35 and 40, and functional class 1, class 2 to 4, and presence or absence of the cardiac arrest or the hemodynamic instability. These are the three things we have to consider for the, that is the selection of the patient for the device therapy.
For upgradation.
Duration 40 days post, right?
No, so upgradation of the pacemaker. So we have to upgrade this device.
Yes, if the ejection fraction less than 30 and the patient has got the Brady criteria, then it is not the simple pacemaker. It should be that is the CRTD.
Then we should remove the system, or we should put additionally CRTD actually.
No, we have to remove the, that is, we have to change the leads. That is the RV lead will be only, that is a classic CRTD criteria, not the, that is the atrial lead will be okay, but RV lead and the CS lead you have to put.
Yes. Thank you, sir.
Sir, I have 2 more cases, so I have to go fast, sir.
Sir, sir,
Two
it is
more cases
already
today or next day, Mamun?
Sir, it is already 10:40.
আমার মনে হয় next day করলে ভালো হয়।
আমার মনে হয় Mamun, you
Sir,
are also welcome for
Sir,
the
this case is not completed yet, sir.
You
ও
complete
এটা
this.
কমপ্লিট করো, এটা
Complete
কমপ্লিট
this
করার পরে
one.
বাকি দুটাকে নেক্সট ডেতে করো।
কারণ আজকের প্রেজেন্টেশনটা খুবই ভালো হয়েছে এবং খুবই আমার মনে হয় যে আমাদের পার্টিসিপেন্টদের জন্য ইউজফুল ডিসকাশন।
Atahar bhai,
হ্যাঁ,
let him finish this case and then stop.
ওকে
Yes,
ওকে
yes,
ওকে
yes.
ওকে। মামুন
So,
প্রসিড অন।
so revascularization was done. Actually, PCI to 3 vessel was done. Then we plan for PPM with a hope for complete heart block resolution. It's not working. But after 8 days of revasculation, there is no resolution of complete heart block. So we finally implanted a permanent pacemaker, a plan for permanent pacemaker. So before putting the permanent pacemaker, so what should be the pre-implant DPT strategy? Here is the choice. Here is the options. So this is the slide showing the DPT strategy. In case of implantation, it is the first implant, so it is a low procedural bleeding risk. And if we consider the thrombotic risk, it is less than 1 month of PCI, so it is a high thrombotic risk. In that case, we can continue the both aspirin and the P2Y2 inhibitor according to the guideline. So here is the ECG after the permanent pacemaker, showing normal standardization and calibration. there is a pacing spike before the QRS complex, and PR interval is fixed. So this indicates that there is a synchronic AB synchrony. And if you look at the V1, there is LBB morphology. So this is a dual chamber pacing ECG in which atria is sensing and ventricle is pacing. Here's the ECG patterns in dual chamber pacemaker. This slide was taken from the Baltazar ECG book, and 4 things can happen. Atrial pacing, ventricular pacing, it is easy to recognize from the surface ECG, as there is 2 spike before POF and QRS complex. But in case of atrial pacing only, there is pacing spike before the POF, but there is no spike before the QRS complex. So there is atrial pacing and ventricular sensing. The third one is atrial sensing and ventricular pacing. In that case, there is no spike before the POF, but pacing spike before the QRS complex. That is atrial sensing, ventricular pacing. And if patient is in the sinus rhythm, that is own rhythm, there will be no pacing spike. In all 4 this ECG pattern, the PR interval will be fixed. So differentiating between single chamber and dual chamber is PR interval. If PR interval is fixed, that is dual chamber pacemaker. If PR is variable, that is most likely single chamber pacemaker. This slide, okay. And that's the end of the slide. Case second.
So what is the ejection fraction, Mamun, before pre-implant ejection fraction of that patient?
Pre-implant ejection fraction was like 41 to 42 something.
Sir, thrombolysis worked in this patient.
True.
True. There was a channel in the LED. Flow was
Right.
re-established.
So, Mamun,
Yes, sir.
so you put the dual chamber pacemaker, now what is the risk of, that is the subsequent risk of this patient? That is the,
In case of dual chamber pacemaker, as there is RV pacing, my patient develop failure, LVF may go down.
so it is just 40, na?
40, 42.
But did you put the ventricular lead? Apex or septum? Or his bundle?
No, that is the RB, that is the LBB morphology, so it was not in the septum, it was the apex.
Apex.
The patient, actually, it was better to put the septal pacing, and more better was the conduction system pacing. And if there is a chance of the more than 40% of the pacing, that is, if the patient has got chance of 40% pacing out of 24 hours, he should go for the CRTD.
Yes.
Oh.
Sir, can I go for third case, sir?
No.
না না
Not
স্যার
today.
আজকে বোধহয় থাকুক স্যার, কারণ
না,
আজকে
না, না।
অলরেডি
না, আজকে থাকুক এবং মামুনই নেক্সট ডে প্রেজেন্ট করুক। মানে মামুনের এটা হচ্ছে যে মানে শেষ করা হলো না, স্থগিত করা হলো।
To be
স্যার
continued.
আমি আতার স্যারকে
মুলতবি।
রিকোয়েস্ট করব এই
এই
প্রেজেন্টেশন
সপ্তাহের জন্য মুলতবি।
বলে আজকে আমাদের ডিসকাশনটা শেষ করতে। আতার স্যার,
তার আগে আমি রিকোয়েস্ট করব আমাদের এমজি আজমকে, আজমের ছাত্র আজম,
স্যার
আমরা এনকারেজ করছি আমাদের এই ফোরামে মামুনের মতো, মামুনকে আজকে আমরা উৎসাহিত করছি যে মামুনের মতো আরো যারা আছে তারা সবাই এসে প্রেজেন্ট করুক। এটা একটা মানে লার্নিং এবং একটা ফোরাম, যেখানে আমরা মামুনকে থ্যাঙ্কস জানাচ্ছি, অ্যাপ্রিসিয়েট করছি, এবং সেই সাথে আমি এমজি আজমকে রিকোয়েস্ট করবো কিছু বলার জন্য, যে আমাদের মামুনের যেরকম প্রেজেন্টেশন সুন্দর হয়েছে, ইন্টারাকশন সুন্দর হয়েছে, এবং তার স্লাইডগুলো ছিল খুব নাইসলি প্রিপেয়ার্ড। আজম কিছু বলো।
ধন্যবাদ স্যার। আমি তো স্যার সবসময় এই প্রোগ্রামের সাথে জড়িত আছি, ছিলাম, আছি, থাকবো। এবং আমার প্রত্যেকটা ফেলো স্যার প্রেজেন্ট করেছে স্যার, আপনি দেখছেন এর আগেও কোভিড এর সময় ফয়সাল করছিল, তারপর কিছুদিন আগে আলামিন করছিল, এবার মামুন করলো, তারও আগে। তো আমার মনে হয় স্যার আমাদের উচিত যারা যারা ইমার্জিং লিডার যারা আছে তাদেরকে খুঁজে বের করতে হবে এবং তাদেরকে বেটার ভিজিবিলিটির জন্য পোডিয়ামে আনতে হবে এবং তাদেরকে আমাদেরকে আনকন্ডিশনাল সাপোর্ট করতে হবে ফর পার্টিসিপেশন, প্রেজেন্টেশন। যদি সুযোগ থেকে তাদেরকে কোনো বেটার জায়গায় আমরা যদি তাদেরকে সেট করতে পারি, হ্যাঁ, বেটার ভিজিবিলিটি বলতে বোঝাচ্ছি আমাদের দেশে বিভিন্ন প্রোগ্রামগুলোতে এবং ইভেন বাইরেও যদি আমরা তাদেরকে প্রমোট করি, তারা আমাদের জন্য মানে অনেক সম্মানই বয়ে আনবে আমি বিশ্বাস করি আর কি, এবং আমরাও বেশি গৌরবান্বিত হবো আর কি। ভবিষ্যতে আমি আরো বেশি পার্টিসিপেশন আশা করে স্যার আমার বক্তব্য শেষ করলাম স্যার, ধন্যবাদ।
হ্যাঁ, ঠিক আছে, থ্যাংক ইউ। নাকি রেজওয়ানা, আমরা এর আগে রেজওয়ানা রিমার একটা পেডিয়াট্রিক প্রেজেন্টেশন শুনছিলাম, আমরা রিকোয়েস্ট করব রেজওয়ানাকে পরবর্তীতে একটা সিরিজ অফ পেডিয়াট্রিক প্রেজেন্টেশন দেওয়ার জন্য। এবং আমাদের শরীফুলের আজকে তার মানে ডিসকাশনটা এবং পার্টিসিপেশনটা খুবই এক্সেলেন্ট ছিল, সেজন্য শরীফুলকে ধন্যবাদ। আমরা নেক্সট টাইমকে শরীফুলকেও রিকোয়েস্ট করবো যে যদি সুযোগ পায় তাহলে এরকম ফোরামে প্রেজেন্ট করার জন্য। আব্দুল্লাহ জামিল কিছু বলো এবং তারপরে শেষ করো।
হ্যাঁ, আজকের দুইটা কেস দেখতে এক্সেলেন্ট ছিল, আমরা অনেক কিছু শিখলামও এবং এনজয় করলাম খুব। আশা করি আমরা আমাদের কাছ থেকে এরকম আরো বেশ কিছু কেস বেস ইসিজি আমরা শিখতে পারবো
ইনশাআল্লাহ স্যার।
ধন্যবাদ।
আচ্ছা মামুন, তাহলে তোমার এটা
Yes.
আজকে স্থগিত করা হলো, তুমি নেক্সট টাইমে আরো 2টা বা 3টা কেস রেডি করে একবারে প্রেজেন্ট করো, ঠিক আছে?
ওকে জি স্যার, থ্যাংক ইউ স্যার।
Presentation আজকে খুবই ভালো ছিল, থ্যাংক ইউ ভেরি মাচ ফর ইউর পার্টিসিপেশন এন্ড প্রেজেন্টেশন, এক্সেলেন্ট, নাইস স্লাইড ছিল তোমার।
থ্যাংক ইউ
Thank
স্যার। আসসালামু আলাইকুম স্যার।
নমস্কার। আল্লাহ হাফেজ, গুড নাইট।